Wendy, I've made up.
Good morning, everyone. I hope you can hear me, even if you can't see me with my height. So, first of all, I wanted to give you a bit of context of Wolverhampton. Just bear with me, just make sure this is moving. There we go. So, it's a comprehensive acute hospital, but it's got some differences maybe to others. There's a community element, there's tertiary services, and we have 11 GP surgeries that are now aligned to the Trust. It's an ethically diverse region in the West Midlands with 450,000 people. We have 90 different languages in Wolverhampton, and 36% of our residents are from ethnic minority groups. We have a workforce of around 9,500 staff and more than 350 roles. We're halfway through a patient experience enabling strategy with our regional colleagues at Warsaw, and congratulations to them also today. And that strategy underpins everything that we do around patient experience. So we're quite pleased to see that complaints has been reintroduced as a category. It's not the pink and fluffy stuff sometimes, is it? It's a hard graft. It's the thankless job that sometimes feels like. But it's about listening, and not just listening, but actively listening. And how do we really measure that we've listened and understood beyond data or statistics? So the background to our project was really about the NHS standards. It's about really learning from complaints and moving away from a blame culture. So we wanted to really introduce effective methods for analysis and reporting that are critical to defining the possibilities for organisational development. And I know that's something that we're all tasked to do when it comes to complaints is, well, what have we learned? So like so many trusts, particularly during COVID, we experienced so many deaths and we nursed so many patients through end-of-life care. And this is what we wanted the focus to be on. It's the most emotive time for people. We may not be able to dramatically change the outcome, but we could try and ensure that we gave as much of a positive experience at the end of life that we could, giving the families a positive memory to take away of their last moments with their loved one. So our commitment to learning at RWT is around the inspiration of that, how we listen to that qualitative feedback, the what, the when, the how, the inventiveness, what tools have we got given the financial restraints, and how we identify at which point during the journey that something went wrong. We know very often that a patient could have a really positive journey from the beginning, from admission to discharge. And if something goes wrong at discharge, it's tainted the whole view of their experiences. And we wanted to identify at what point did things go wrong, if they did. And we wanted to really improve and drive through any learning. And part of that was really organisational culture. Is how do we make sure that patient experience is seen as everybody's responsibility and not just ours? So we really wanted the voices of the patients and their loved ones to be amplified through their complaints, some of it retrospectively following the death. Some of the complaints were before the person deceased. And we know that end of life is categorised within the 12 months leading up to the death of the loved one. So there was reoccurring themes and some national drivers around looking at end of life. We've got the Ombudsman, the reoccurring themes around end of life nationally. We've got known variations in service provision and standards, and thinking about the complexity of the trust that we have and the service provision. And then a drive to underpin the national framework for local action. So I'm going to hand you over to Professor Wendy Walker, who will talk about the methodology of the project that we undertook. Thank you.
Thank you. So I'm going to move on and just give you an overview of the actual project itself. It was a service evaluation. We used existing data, and that data was the letters of formal complaint. We use the published healthcare complaints analysis tool that some of you may be familiar with, and that was our theoretical framework. And our focus was on the pre and the post-death care experience within those letters of complaint, particularly the adult complaints. The project was 2 stages. The preliminary work was really to apply that HCAT tool where we could derive the actual end-of-life care concerns. And then stage 2 was actually to test those end-of-life care concerns within another subsample of formal complaints. And we wanted to see how reliable that was as a coding and categorising scheme. This slide just gives a very brief overview of HCAT, the 3 problem domains and 7 problem categories. And we also, in the preliminary work, applied the stages of care to detect exactly in what context the actual concern occurred. And the outcomes, well, of our pilot work and our preliminary work was to develop a particular tool, which we've termed as LCAT, an end-of-life care complaints analysis tool. It still incorporates the 3 domains and problem categories, but we have this specific template of commonly occurring 25 individually derived end-of-life care concerns. And as Alison said, we're a combined trust of acute and community, and therefore we found a need to reject the stages of care from HCAT and develop some new context of care concerns to represent that patient-family journey of complaint that may start within a GP surgery and culminate, sadly, in a hospital death. And this is just an example of our template of concerns. You'll see the domain of relationship problems, communication, the problem category, and our specific end-of-life care concerns here were quality of communication and unmet needs. And our example indicators help to guide the analyst. These are some of the ways in which our tool is beneficial in terms of being able to measure the success and impact. And most importantly, we've got informed improvements in care. We have found through our complaints analysis over 3 years that communication is the commonly occurring theme. We have 3 targeted interventions in progress, including a compassionate communication charter. We're going to review the updates for families at the morning huddle, and also a quality improvement project, something that's small in our world in terms of a telephone communication, big in the world of families at the end of life. We have to acknowledge some of our limitations because this was a piece of work that was developed in one single organisation, and we would love the opportunity to go out and test the reliability and validity of our framework in other organisations. We have done a small pilot within our partner organisation, which I thank them for, and we have found consistency in the concerns that we identified. But it's watch this space for the next piece of work. I think our overall conclusions are that this systematic approach that we've adopted and utilised in practice does support organisational learning, quality improvement, and these bespoke service improvements, right down to the actual concern that originates from those original patient and family complaints. So at end of life, as you know, we do only get one chance to get it right. So let's turn our complaints into compliments. This is a feedback that we had from a bereaved family member that really is inspirational. We do have some success in our results from our project in that our number of formal complaints has decreased over time, and it's lovely to be able to give that positive feedback to staff alongside being able to have those targeted interventions regarding concerns. So let's unlock the learning in our formal complaints, and we believe our tool is an enabling piece of work to achieve that. I appreciate in 10 minutes it's hard. I want to tell you so much about the project because we feel very pleased and proud of what we've achieved. but we do have a paper that's being published. It will be out, all being well, next week in the Journal of Healthcare Management. So please do look at that and get in touch with us if you'd like to find out more about our work. And finally, we'd just like to acknowledge the developers of HCAT, who were very inspirational in terms of driving forward our work. And thank you for coming along to our presentation today.